So thank you very much for the invitation to give a talk today. What you can see here is that we're going to talk about guidelines for NF1 tumor surveillance, and that these guidelines is the work of the European reference network GENTURIS. The European reference network GENTURIS is part of 24 networks that have been selected in Europe, and GENTURIS is the genetic tumor risk syndrome. It's one of the 24 European reference networks. It consists of a group of expert centers from different countries in the European Union. And as you can see here on the left side, one of the topics of the GENTURIS European Reference Network is neurofibromatosis. Other topics are Lynch syndrome and polyposis, breast and ovarian cancer, and other rare.
Eric, you are on mute suddenly. Please, sorry, for some reason. Now,
do you hear me now?
Yes. Yes, now I can hear you again.
Yeah, okay. So the European Reference Network about genetic tumor risk syndromes consists of 4 different thematic groups. One of the thematic groups is on neurofibromatosis. Second one is on hereditary colon syndrome, colon carcinoma and polyposis syndromes. And the third one is on hereditary breast and ovarian cancer. And the fourth one is on other rare GENTURIS syndromes. Okay, so within the different thematic groups, one of the tasks of the European Reference Network is to come up with guidelines for surveillance and management of specific tumors of the rare tumor risk syndromes. And therefore, also in the thematic group of neurofibromatosis, we have been working on the development of guidelines for surveillance and management of tumors in NF1. We connected with the experts from the different countries that are part of the European Reference Network, but we also connected to additional European and also experts from the United States that are not part of the European Reference Network. We started with a literature review, and then we came to consensus statements on the surveillance and management of tumors in NF1 through a Delphi procedure. So what is a Delphi procedure? During this procedure, an anonymous questionnaire is sent out to the different experts. They can, in an anonymous way, comment on all these different statements and guidelines that are suggested in this questionnaire and give their opinion if it's okay or not. And then all these results come back. The experts look again at it. If there is consensus about a certain recommendation, then this guideline is accepted. If there is no consensus, we can go for another round, change the recommendation according to all the different suggestions, and then see if we can get to a consensus. And after several rounds of questionnaires, we reached consensus on every different recommendation. And we also afterwards gave a certain strength to a recommendation, if this is a weak, a moderate, or a strong recommendation. As you can see here, a document was prepared. This document is nearly ready, but is not yet published. And many different experts have been participating in this guideline document. And some were geneticists, some were dermatologists, other pediatricians, neurologists, psychiatrists, radiologists, oncologists, and so on. So we try to get a specialist from every different specialty in medicine that has something to do with the detection and the surveillance and the treatment of tumors in neurofibromatosis type 1. This is an example of such a recommendation. So this is a general recommendation, and it says that based on the risk of occurrence of tumor complications in NF1, systematic clinical assessment by NF experts at regular intervals is advised, with a minimum of every year in children up to 10 years, every 2 years in children older than 10 years, and every 3 years in adults. And this is a minimum, so you can do more than this, but it is not advised to see patients less frequently than what is advised or suggested here. And during transition from adolescence to adulthood, it is appropriate to have more frequent systematic clinical assessment. So this recommendation is done saying that it is important that individuals, both children and adults, have a regular systematic clinical follow-up by NF experts. The strength is weak because we do not find studies in the literature that say that strongly support this, showing that if patients are followed by in this way, that they do a lot better. But the opinion of the experts is that this is really something you should do. Therefore, the strength of the recommendation is weak. So we made recommendations for all these different potential tumor types that you could see in someone with neurofibromatosis type 1. So the optic pathway glioma, which is especially important in children, but also non-optic pathway gliomas in children, in adults, the malignant peripheral nerve sheath tumor, the plexiform neurofibroma around the eye, plexiform neurofibromas at other positions in the body, skin neurofibromas, tumors in the intestine, in the intestinal tract, tumors of the adrenal cortex, the pheochrom, or the adrenal medulla, excuse me, the pheochromocytomas, breast cancer, tumors in the digits, so in the tips of the fingers, a very rare type of leukemia. And then, of course, we also made recommendation on the psychological needs of patients in which one of these tumors has been detected, or if they are under surveillance for one of these tumors. It is very important that also people take care of their psychological needs. In total, about all these different items, 67 recommendations were made, and also the strength of the recommendation was scored. I'm not going to go through all these 67 recommendations, but I will show you a couple of examples. The full document that has been prepared contains 135 pages, and the summary of these recommendations will be turned into a scientific paper that will be submitted to a scientific journal in next year in 2022, so that these recommendations are available to every person who can read them in the scientific journal. So to every medical doctor, to every person who works in healthcare, but they will also be available on the website of the European Reference Network, so that also patients can take a look at them. So there are a couple of recommendations made for a systematic screening of a specific tumor type. It was recommended to do a systematic screen with an ophthalmologic examination at least every year until the age of 8 to detect optic pathway gliomas in children. And after the age of 8, it is recommended to do an annual visual testing till the age of 18. So it was thought that the best way to screen for optic pathway gliomas is to screen with an ophthalmologic examination, so by the eye doctor, and not by doing every 1 or 2 years an MRI scan of the brain. For non-optic pathway gliomas, it is recommended to screen only once with an MRI of the brain at the age of 16 to 18 years, so at the age of transition from adolescence to adulthood. Also for plexiform neurofibromas, it was recommended to screen at least once at the age of 16 to 18 years by a whole body MRI, so that it is possible to see if there are internal plexiform neurofibromas that are not visible from the outside during the clinical examination, and the extent and the localization of these potential internal plexiform neurofibromas are very important, because they will determine the further follow-up of these tumors in adulthood. If there are no internal plexiform neurofibromas seen at the age of 16 to 18, it is expected that the chance that they will develop later on and cause some problems is very, very low. I already told you something about the pheochromocytoma. These are tumors of the medulla of the adrenals. So these are little glands on top of the kidney. And they can secrete a lot of adrenaline and cause hypertension. And if they cause hypertension, they also can cause brain hemorrhage. It is not recommended to screen systematically all adult individuals, because this is something that occurs predominantly in adults, or virtually only in adults. But to screen in a systematic way all women who are trying to get pregnant or in the beginning of pregnancy, because delivery of a baby is associated with a potential high level of secretion of these adrenaline and noradrenaline by a pheochromocytoma, and can be potentially very dangerous during the period of delivery. And then the last item that was recommended for a systematic screening was the screening for breast cancer in women with neurofibromatosis type 1. And it was recommended to screen yearly between the ages of 30 and 50 years, and then from 50 years on to follow the population screening of the country. And it was recommended that if possible, the screening should be done by MRI of the breasts. If MRI screening is not available for this indication, then mammography is advised. This is the result of the fact that in the last couple of years, it was shown that there is indeed a slightly increased risk for breast cancer in women with neurofibromatosis type 1. And this is limited to the age period between 30 and 50 years. So the total number of breast cancer cases is not severely inflated or increased. It's only a marginally increased number, but the risk starts a lot earlier. So here you can see that the risk at between 30 and 40 years of an individual with a woman with NF1 is higher than in a general population. And general population is thought that only 0.5%, so 0.5% of women between 30 and 40 will get breast cancer. And as you can see here, the risk is a little higher. It's between 2 and 5.5%, depending on the different studies. The risk of getting breast cancer between 40 and 50 is in the general population 1.6%. And in individuals with NF1, it is somewhere between 4 and, in this case, in this study, even 14%, but that's probably a little bit too high. But for this reason, it is recommended to start screening earlier than the age of 50, which is in most countries the average age where all the women in the population will be screened for breast cancer. This is an optic pathway glioma. Here you see the two eyes, and this is a brain scan through at the level of the eyes, and here you see the brain, and this nerve, this eye nerve, is severely thickened due to an optic pathway glioma, and you see that the optic pathway glioma is pushing the eye forwards. And you see that the position of this eye is different from the position of the other eye. And this is a plexiform neurofibroma that you can see when you examine a child. It is an enlarged, so the soft tissue is thicker. You see that the hairs are longer and that the skin is darker. And these are the hallmarks of a superficial plexiform neurofibroma. But internal neurofibromas cannot be seen by clinical examination, and there you need, of course, an whole-body MRI. This is an MRI through the abdomen. So these are the lungs. This is the liver. Here you see both kidneys, and you see a little tumor here on top of this kidney on the left side here, right? And it's a tumor of the medulla of the adrenals. It secretes products called catecholamines, so noradrenaline and adrenaline. It can give headaches, palpitations, sweating, hypertension, and sometimes it's just a coincidental finding on an MRI scan. You can diagnose it that it's active and secreting catecholamines by analyzing the urine or the plasma, and screening in pregnancy is recommended. When an active secreting pheochromocytoma is detected, it is recommended to remove it through surgery. All the other tumor types that can be present in individuals with neurofibromatosis type 1 should be investigated based on the clinical examination and on the complaints of an individual with NF1, but not systematically at every visit. You need to do all kinds of MRI scans and so on. An example is a malignant peripheral nerve sheath tumor. This is a plexiform neurofibroma that has become cancerous and malignant. And people should think of the possibility of a malignant peripheral nerve sheath tumor when you have one of these things that are present. One is growth of a neurofibroma, of a plexiform neurofibroma with a rapid increase in size or a change in the growth rate. So it's not rapidly increasing in size, but more rapidly than before. Pain is also an important issue. When there is new pain and it persists for, let's say, 2 or 3 weeks, then, and especially when it's difficult to control, then it might point to a malignant peripheral nerve sheath tumor, and investigations to rule out or to show an MPNST should be performed. Other things that might point to a malignant peripheral nerve sheath tumor is the appearance of a motor weakness. So when the muscles are not that strong anymore of one arm or one leg, when there is a deficit in the sensory system, meaning that you don't feel very well with the skin what's going on, so you have a sensory deficit in a region where you have a neurofibroma, or other disturbances of bladder function, bowel function, swallowing, breathing, and so on. Also, when the consistency of the tumor is changing, especially when you have a hard nodule that develops in a previously soft plexiform neurofibroma, then this might indicate a malignancy, and the individual should be investigated to rule out or to show a malignant peripheral nerve sheath tumor. But these are all clinical findings, and therefore it's important that also adults come for a regular clinical visit to screen by a clinical examination and by questioning if there is any symptom that might be connected or point towards a malignant tumor. Here you see MRI scan. This is the vertebral column. This is the neck. And these are the lungs, the tops of the lungs. And on the left and the right side, you have the shoulders. This patient complained of pain in the neck in this region here. But there are many different tumors, so you don't know which one of these tumors is really actively growing and causing the pain. And if you do a PET scan, you can see that it is exactly this tumor here, which you can see there, which is causing the pain also here. You can see with another, this is a CT scan. So in this region, this tumor that is sitting there is causing the pain. So when you cut it in this region like this, you get this image here. And then of course, you know that these tumor cells are more actively dividing because they're taking up a lot of glucose, which is a sugar that makes them, that gives them energy to grow. And then, of course, you have to see if you can remove this tumor or not, because there is a very high chance that this is a malignant tumor. Quite often, people first do a biopsy to make sure that it is benign or malignant, and then they remove the tumor, because the surgery is different for a malignant tumor than for a benign tumor. And here are the different recommendations that are made for plexiform neurofibromas. You see there are 10 different recommendations for plexiform neurofibroma. It says clinical assessment should be by observation, palpation, and neurological examination, and should be done at every clinical visit by a person who has expertise in neurofibromatosis, combined with photography and a video if necessary. It should start, the clinical assessment should start as soon as you know the person, and should be carried out at every visit. And imaging to monitor the plexiform neurofibroma should be performed at least at transition from childhood to adulthood, between 16 and 18, to see if there are internal plexiform neurofibromas present as a predictor for malignant peripheral nerve sheath tumors, and to find out how this person has to be followed later on in adulthood. The frequency of how often you have to do the imaging has to be decided on an individual basis. Clinical monitoring should start when it's first detected. And when the plexiform neurofibroma causes symptom, then it requires increased monitoring, because when it's causing pain or weakness of the muscles, then it might be a tumor that is in its transition phase from benign to malignant, and that's called an NF, or it might already be malignant, and then it's called an MPNST. To make a difference, to make the difference between a completely benign tumor and a tumor that is already becoming malignant or is already malignant, the PET scan is the most important examination to perform. And one of the first things to consider if you need to treat a plexiform neurofibroma is surgery, but quite often surgery is not possible. And if possible, based on the country where you live in, MEK inhibitors may be considered as a treatment option for symptomatic and inoperable symptomatic plexiform neurofibromas. And the management should be decided and performed by a multidisciplinary group, so with doctors from different specialties who have expertise in neurofibromatosis type 1. And given the burden of having a potential risk of malignancy and visible manifestations, in NF1 individuals with plexiform neurofibroma, those individuals should be offered psychological support. So this is now one example of the whole set of recommendations that was prepared in this case for a plexiform neurofibroma. Here you can see a whole body MRI on the right side, and there are three larger tumors seen here, one with the blue arrow, the green arrow, and the yellow arrow. And then, of course, it's important to know which of these tumors is potentially growing, which is taking up most of the glucose sugar that's in the blood. And then you see that only the blue tumor is taking up an increased number of sugar because it turns red. And this is when you cut in this way, according to the blue line here, you get this image, and there you see also that that particular tumor localized at the right hip is picking up more glucose than the other two tumors who are not visible here on this scan because they're not taking up an additional amount of glucose. So this is a tumor that is suspicious of being in a transition phase from benign to malignant. And indeed, this tumor, when it was removed, turned out to be an ANP or an atypical neurofibroma that was in a transition phase from benign to malignant, but was not yet malignant at that moment. And this shows you how these recommendations work in real life. Of course, this tumor was removed. And then I want to say one word on the glomus tumors of the fingertips, because these tumors are not so rare in adults. At least 5% of adults will experience in some time in their life a tumor at the tip of the fingers, and the tumor can be localized under the nails, and you can see a split nail. Here also at the right lower image here, you see the tumor at the fingertip and the pressure it exerts on the nail. And you see also that the nail is deformed. Sometimes, as you can see here, there is a little swelling to see, but most of the time there is nothing to see. It's a normal fingertip, but it hurts a lot. And the pain becomes worse in the winter. It becomes better in the summer. And it is very localized, the pain. Once a diagnosis of a glomus tumor is made, it is relatively simple to remove it by surgery. But people who are not diagnosed with this tumor, they will have, or they have the risk of having a severe pain for years and years without the diagnosis. So these guidelines will be published in the literature, but they will also be published on the website of the European Reference Network GENTURIS. And you see here, this is a screenshot from the website. They have already published guidelines on other genetic tumor conditions, and we hope that neurofibromatosis type 1, type 2, and schwannomatosis will be on there next year. I thank you for your attention.